Hello, can you hear me? Hello, can you hear me?
Yes, sir, we can hear you, sir.
All right. Sorry for the delay in starting. I had a connectivity issue. I couldn't connect to the internet. Can you let the others know now we are going to start, because only I can see only about 40 odd people are here. So I'll wait for a couple of minutes for the others to join. Okay. So today what we are going to discuss is about problems of the thyroid gland. So how it's going to go is I will give the introduction to the CLD. After my introduction, Dr. Sachit Taberatna will take over and discuss the medical part of the discussion, medical with the pathophysiology, with the physiology part, and then management of Graves' disease. And from then onwards, I will again take over and discuss the surgical part. Right? So these are the things that we are going to cover during this discussion. Briefly, the anatomy, and there's nothing much on anatomy. Physiology, Sachit will discuss the physiology of thyroid hormone production, and then we'll go through different conditions which may increase in size of the thyroid, including multinodular goiters, toxic goiters, then cancers, and thyroiditis. Briefly at the end, we will go through the pathophysiology of each of these conditions in brief, and then we will try to concentrate more on history and examination as well as investigations. And the last part would be the most important: principles of management of each of these conditions that the causes leading to enlargement of the thyroid. So we will go through indications of interventions, the types of interventions, and how to select the optimum or the best intervention when you have more than one intervention available, and benefits and side effects of each of these interventions as well. Already I have given you two SCQs to go through. So first one is a 50-year-old female who undergoes a total thyroidectomy for carcinoma. 4 possible causes of post-operative upper airway obstruction that may occur in this patient. Explain the pathophysiology of each of the complications. Outline the treatment of any of the complications. So I hope the wordings and things are correct. This is the question I was given. Hopefully, I'll have gone through this. At the end, we will try to find the answers to these two questions. The second one is discuss the differences in pathophysiology of hyperthyroidism, Graves' disease, and toxic MNG. Discuss the differences in treatment of the two conditions mentioned in previous relating to differences in pathophysiology. Two complications each for the modalities of treatment mentioned. Again, we will go through this at the end. Okay, starting off, essentially, the conditions that we are going to cover will be broadly 4 conditions or 4 situations. So we will try to correlate these conditions or these clinical scenarios to the theory that we are going to discuss a little later. So think of this situation: a young female, 23-year-old, presents goiter of 6 months, roughly this kind of a person. She has palpitations, loose stools, significant weight loss despite good or increased appetite. On examination, anxious, tachycardic, and hypertensive. Thyroid gland is symmetrically enlarged. It's firm and non-tender. There is a bruit as well. There is lid-lag, exophthalmos, and proptosis. You can see in this picture. TSH is low, T4 high. I guess you all can make the diagnosis. This is a patient with Graves' disease. So the next question is, how should she be further evaluated and treated? We will try to find the answer. Sajid will discuss that part. Then the next patient, slightly oldish male. Again, somewhat similar picture: weight loss despite an increase in appetite, increased sweating, palpitations, small goiter. You can see there's a goiter involving both lobes. Again, tachycardic, hypertensive. Differences: there's a lid-lag, but no other eye signs. Again, low TSH, T4 level is high. So the diagnosis here would be a toxic multinodular goiter. Then how this patient should be managed is what we are going to discuss: assessed and managed. Third situation, middle-aged woman with a goiter for 5 years, euthyroid, no compressive features, just a multinodular goiter. What should be done? So the first situation is a 42-year-old woman with a mass on the right side of the neck, no other significant symptoms. But on examination, it's a solitary hard nodule, 4 by 5 centimeters in size, no palpable nodes. So what should be done? So here we have a suspicion whether this could be a malignancy. So we are broadly trying to cover 4 conditions: Graves, toxic multinodular goiters, a simple multinodular goiter, and a nodule suspicion with a suspicion of malignancy. Right. So keeping all these things in mind, the 2 SCQ questions that we have just briefly gone through and the 4 different clinical scenarios, we'll get into the discussion. Now what we will do is Sachit will take over from this point onwards. I will allow him to share, and then we'll take it from there onwards, the rest of the discussion.
Okay. Thank you, Sanjeev.
I'll make you the host so that you can take over from here.
Still, I can't share the screen.
Yeah, I'm trying to find your name in the list.
To go the top, probably, maybe others are also in this.
Yeah, yours, yeah, right at the top. Okay, so you are the host now. You can share. I'll move out. Okay, Sakit.
Okay, thank you. Yeah. So students, I hope that you all can see the screen. Can you see the screen?
Yes, sir.
Right, okay. Right, so what I'm going to do is I'm going to discuss about the medical part, then Professor Sanjeev will continue with the other areas of the management. Okay, just to refresh your knowledge on thyroxine hormone production. So it's important to know because when we use multiple medical therapies, we target different areas of thyroxine hormone production. So I hope you'll remember your physiology just to refresh that. So first, the iodide is transported into the follicular cells by a iodide co-transporter, and then iodide is turned into iodine, that is by important hormone, important enzyme. Can you remember the name? What is that important enzyme? Yeah, anyone? Which is involved in the oxidation process? Yeah. Well, you must be remembering that there's only one enzyme we talk about now in this area. What is the enzyme?
Thyroid peroxidase.
Yeah, thyroid peroxidase, right? Okay. So then there is organification. These tyrosine residues, they combine with iodine, and then coupling procedures happen. Then diiodo and triiodothyronine, tetraiodothyronine, and the triiodothyronine, those are formed and stored with the colloid. And when the need arises, these will be released into the system. And yeah. And then once the thyroxine is released, major part is T4. But before they go and enter into the cells, they will be deiodinized into T3. So at the tissue level, most important hormone is T3 rather than T4. So this peripheral conversion is also important, and you know that there are certain medications we'll discuss later that block this conversion as well. And then the receptors are intranuclear. So the thyroid hormones will travel to the nucleus, and they cause changes in the transcription of gene. And by way of that, they control major processes in the body. I mean, almost all cells will utilize these thyroxine hormones. So it is involved in growth, central nervous system maturation, controlling your basal metabolic rate, metabolism, glucose, lipids, protein metabolism, and there are a lot of cardiovascular effects related to the thyroxine hormones. So those are through these pathways that will happen. And then it's very important to remember the hypothalamic pituitary axis. It's through pituitary will secrete, the hypothalamus will secrete TRH, and then TRH will stimulate TSH release. And then can you remember, is there any other hormone TRH will stimulate other than TSH in this pituitary axis?
Prolactin.
Prolactin, okay, good. So you still remember that, right? Then the TSH will come in, and the TSH will stimulate thyroxine hormone release. Majority will be T4, and part of it will be T3. But at the tissue level, most of the T3 will be turned into T4 will be turned into T3 before they bring about action. So that is important to know. So as I mentioned before, most of the cells in your body will utilize these thyroxine hormones. And when there is deficiency or increased levels of thyroxine, there will always be changes in multiple systems. So you will have multiple signs and symptoms when you have thyroid disorders. Now, disorders can be categorized into several categories based on function. We divide into hyper and hypothyroidism. Hyper, there are multiple causes. Main three are the Graves, toxic multinodular goiter, and toxic nodule. So I'm mainly focusing about Graves. Professor Sanjeev will discuss about the other etiologies. And then thyroid cancers are there as neoplastic ones. Then when you take multinodular goiter, it can be sporadic, endemic, or familial. And then there is inflammatory conditions like subacute thyroiditis, which cause increased thyroid levels. Right, so before we move on, can any one of you explain what is the difference between hyperthyroidism and thyrotoxicosis? Are they same, or is there any difference?
The difference in thyrotoxicosis, it means that the blood level, thyroxine level is high. But hypothyroidism per se is that there is a hyperfunctioning of the thyroid gland and it producing thyroid.
Okay, yeah, correct. Yeah. So when you say hyperthyroidism, the effects are due to increased thyroxine is due to overproduction of thyroxine due to the hyperactive thyroid gland. When you say thyrotoxicosis, it's the clinical stage of thyroxine excess. It could be endogenous, exogenous. So even if you give thyroxine outside, you get thyrotoxicosis rather than hyperthyroidism. Then other conditions like struma ovary and then extra thyroxine therapy from outside, thyroiditis, those conditions, you get thyrotoxicosis. Hyperthyroidism, the gland hyperfunction is there. So it could be Graves, multinodular goiters, solitary nodules. To give excess iodine, the gland will produce too much of thyroxine. So those are the examples for hyperthyroidism. So that's the difference, and you need to know that. Right, so the clinical features, I'm sure you have learned about them, and some of you have seen these patients as well. So if it is severe hyperthyroidism, it's a very characteristically diagnostic, right? You see all the features and it's very easily can be diagnosed. So when you take the signs and symptoms, you're mainly concerned about these cardiovascular effects because they cause more problems. You know, there will be changes in the blood pressure. They increase the heart rate, the thyroxine hormone, increase the basal metabolic rate. They increase the cardiac chronotropic and inotropic effects. So therefore, the pulse rate will be high in these patients and the cardiac output will be high. And therefore, the systolic blood pressure can also be high. But most of the time, the systemic vascular resistance or the afterload will be low because there is increased thermogenesis and vessel dilatation, and therefore the afterload will be reduced, which in that case they have low diastolic pressures. So when you take hypothyroidism, they mainly get diastolic type of hypertension, whereas hyperthyroidism, you get more like systolic type of hypertension and lower diastolic blood pressures. So that is in cardiovascular disease, cardiovascular system. And then in terms of metabolism, it causes weight loss, increased appetite, heat intolerance, and the skin will be warm and moist, sweating. There'll be muscle weakness, mainly the proximal muscle areas. We call that thyrotoxic myopathy. And then there are a lot of central nervous system related changes. So these patients are irritable, they're restless, they get angry more often, difficult to sleep, and they have emotional issues as well. Fine tremors and wrist tendon reflexes you can elicit when you examine these patients. And cardiovascular system we discuss. So they can lead into high output cardiac failure. There'll be tachycardias and can also aggravate atrial fibrillation. Mainly systolic blood pressure or hypertension due to systolic blood pressure elevation is seen in these patients. And in terms of reproductive system, they have impotence, loss of libido, oligomenorrhea, and eyes. There are certain signs and symptoms specific to Graves' disease. I'll explain it a little later, but the common ones are exophthalmos, lid lag, lid retractions. And the GI tract, mostly they will have diarrheas, increased bowel movements, and then respiratory system, they might complain of breathlessness. And then hair loss, alopecia, fine hairs, pretibial myxedemas, and thick brittle nails. Those are some of the other signs and symptoms you'll see in a hyperthyroid patient. And then most of these patients will have a goiter. Looking at the goiter also, that will also give you some clinical differentiation. Now, if it's a smooth goiter with hyperthyroidism, either it could be Graves' disease, or it could be subacute type of thyroiditis, or it could be a nodular goiter. When you feel it, you'll feel the nodule. It could be a solitary nodule, or it could be a multinodular goiter. And I'm sure you have seen these classifications. There are different classifications. For goiter, there's a WHO classifications, and nodules also there's a classification to classify them. So when you take goiters, they could be either euthyroid or toxic goiters, even hyperthyroidism, sometimes you get a goiter. When you have toxic goiters, it could be either Graves, toxic multinodular goiter, solitary nodule with thyrotoxicity, hypothyroidism, and then due to thyroiditis, again you get a diffuse goiter with hypothyroidism, or with thyrotoxicosis, with thyroiditis. So these are the ones. If you get a patient with thyrotoxicosis and a goiter, you have to think of these things. Now, we'll discuss more in detail about Graves' disease. It's an autoimmune disorder. There are antibodies directed against the TSH receptor. So we call them TSH receptor antibodies, or in short, TRAP antibody levels. They are more common. This Graves' disease is more common in younger females. You also know that these autoimmune other conditions are more common in females. So this is a young type of females coming with thyrotoxicosis. You have to think of this Graves' disease as one of the differential diagnoses. Now, the other important thing with Graves' disease is there is associated eye signs. So there is exophthalmos. So in exophthalmos, the eye enlarges and you will be able to see the white area below the dark, the black area. You see the whitish area in the eye. So that is in exophthalmos. And there'll be ophthalmoplegia. There is a defective eye movements. Lid lag is there. So when you do the quickly, you ask the patient to look down. You see lid is lagging behind the eye. And then there is lid retraction. So there will be a kind of a patient with staring look. And then proptosis. So ideally, to detect proptosis, you have to come from above and check that. So the eye comes out. And then the chemosis, that is a redness, where you see in the left side last picture, what you see, that is chemosis of the eye. So the pathophysiology of Graves' eye disease is these TSH receptors are also there in the orbital fibroblast. So when these antibodies comes, they stimulate these receptors, which cause adipogenesis and hyaluronic acid synthesis, which ultimately lead to enlargement of these muscles as well as adipose tissues. Therefore, the eyes will crop out, and that's why you see those other symptoms. And the lid drag and the lid drag retraction, those are mainly due to the increased sympathetic tone. So these ones you will even see in other conditions, other hyperthyroid conditions other than Graves as well. But the others like exophthalmos, proptosis, ophthalmoplegias, chemosis, and those kind of eye symptoms are mainly seen in the Graves' disease. So if you identify eye diseases like exophthalmos, proptosis, ophthalmoplegias with hypothyroidism, you fairly know that it's most likely to be Graves' disease. The most important thing about the eye disease is it can actually cause pressure on the optic nerve, and it can cause corneal ulceration, which can ultimately cause blindness to the patient. So it's a very important sign to detect, and we have to advise the patient to bring it to the medical notice if they develop any severe visual problems, because that is an emergency condition. And then in Graves' disease, you get other things like this pretibial myxedema, and then thyroid acropathy, which is soft tissue swelling. It's quite similar to the clubbing, which you have seen. And then onycholysis, which is separation of the nail plate on the distal margin. So those are also seen mainly in the Graves' disease, not in the other hyperthyroid condition. So pretibial myxedema may be subtle, especially in our patients. It's not so prominent like the Caucasian patients, but if you see symmetrically distributed the changes in the skin in the anterior part of the legs, you have to think about this if they are hyperthyroid. Right. So after that, if you suspect the patient is having hypothyroidism as for any other patient, you have to do the biochemical evaluation for those patients. Because some of the symptoms like anxiety, even anxiety can bring about, like palpitations, feeling hot. Those are not specific things. So definitely you need to do thyroid function tests for that proper diagnosis. So first thing we do is TSH. And if you do that nowadays, it's always third generation. It has high sensitivity and specificity, and therefore you can easily detect this. TSH will be suppressed in all hyperthyroid condition. And then most of the time we do free T4 level as well. That improves the diagnostic accuracy and gives us more information about what is the severity of the condition. Because sometimes if you have seen the reports, it will come as less than 0.001. And we don't know beyond that what is the severity. For that, you need to look at the actual free T4 levels. T3 is optional, but doing T4 would be enough. And the other thing is, based on that, you decide on your starting doses of medicine. And the second thing is, you can monitor how successful your treatment is if you follow up your T4 levels. For that, you need a initial T4. In some patients, even though their TSH is suppressed, their T4 may be normal. Then we do the T3 levels, that is called T3 thyrotoxicosis. That could be seen in Graves' disease patients, especially in the early stage of the disease. So therefore, in those type of patients where T4 is normal, you can then do the T3 levels to confirm the TSH suppression is due to that. And then I told you that the base of the pathophysiology is this TSH receptor antibodies, stimulating type antibodies. We call them TRAP in short. So that can be done. That will give you more details if you do that. But in routine practice, we don't do that because it's an expensive test. And there's a small percentage where TRAP negative disease is also there. So therefore, routinely we don't do it. We go by the clinical features as well, because you know that if they are thyrotoxic and if they have eye disease or peritibial myxedema, it's most likely Graves' disease. But this could be done if facilities are available. And it is one particular usefulness in doing TRAP would be in a pregnant patient with Graves' disease, because if the TRAP antibodies are there in high titers, there's likelihood that the neonate will get thyrotoxicosis, and therefore those features should have to be monitored more carefully if TRAP is positive. So pregnancy it is indicated. Other situations, mostly we might not do that. And don't go away with the idea that all low TSH you see is Graves' disease or one of these conditions we mentioned. There could be other conditions as well. Now I have given you a few situations here. You can tell me at least one condition. Now, what is, can you give me a possible situation for the first condition? TSH is low, T4 is high, T3 is high. Give me a condition. Where would you see like this?
Graves' disease.
Yeah.
Graves' disease.
Okay, Graves' disease. You can see any other condition? Yeah, any hypothyroidism condition. This is the common picture you see. What about the second situation? Low TSH, T4 is normal, T3 is high. Yeah. What is this?
T3 toxicosis.
Yeah, this is T3 toxicosis. So Graves' disease, you can get it, especially in the early stage, right? Third situation, low TSH, T4 normal, T3 normal. Yeah, what is that? Is it error in report or what do you think? that is.
Poor compliance to the drug, sir?
Sorry?
Poor compliance to the drug?
Okay, you can think of other conditions, but the common condition is this is called subclinical hyperthyroidism. You have heard about that term, no? Subclinical, there is subclinical hypo and subclinical hyper. So this is very early. You know that TSH is very sensitive. So early stages, you might see this. This is called subclinical hyperthyroidism. So the treatment depends on situations. Like all subclinical hyperthyroidism, you don't need to treat, but sometimes it may be associated with atrial fibrillation and other problems like if it's ischemic heart disease patients and those types, you still might have to treat. So not all patients will need treatment, but you have to evaluate, you have to look at the progression. They might go into overt hyperthyroidism. So then you have to decide based on that. Okay, coming to the fourth condition, normal or high TSH, T4, T3 both are high. What is that? What is that condition?
TSH.
Yeah, those are the other ones, right? These could be TSH-omas or thyroid hormone resistance. You have to think in that situation. What is the last one? All are low. All are low. Yeah.
Ectopic thyroid hormone secretion.
Ectopic thyroid hormone secretion? No, I don't think that will fit into this picture. And why thyroid hormones are low?
Pituitary failure.
Yeah, so this is a pituitary problem, right? Pituitary problem causing low TSH, but your T4, T3s are low. So that's the main message. Is if you look at TSH, don't go by the idea everything is hyperthyroidism, right? It could be other told you, but these are the important things. The assay any type of this. So if you don't find any of the earlier discussed diagnoses, you can think of assay interference. So if you do funny thyroid function test, which cannot be put into any of these things, you can think of these assay interferences and discuss with the lab. They will repeat it in a different platform and it might solve the problem. So that is how we diagnose. And then after that, so the thyroid function test will tell you what is the situation. They'll confirm your clinical suspicion, and then you can do a thyroid ultrasound scan. And optionally, you can do thyroid uptake scans. We don't do because most of the time, the available you say from a clinical examination. If it's a diffuse goiter, I told you there could be two possibilities. One is thyroiditis, other one is gravely diffusely enlarged thyroid gland. But the color Doppler of the arteries, vascularity, where you will hear a breathe as well. Grave zone. Yeah, anyone? Yeah. So are you all not checking that when you examine the thyroid? Yeah, which condition you think? Gimhani, can you answer that question? Gimhani? Okay, so since the time is going, I'll answer, you all are not answering. So it is in the Graves' disease, right? So Graves' disease, you get increased vascularity. So if you see increased vascularity in your ultrasound scan and with your clinical diagnosis, that will support a diagnosis of Graves' disease rather than thyroiditis. Right, and then you can do the uptake scans as well. So if you do uptake scan, we'll see low uptake, whereas Graves' disease, you will see high uptake. Now, this is the vascularity I have been talking to you. Can I check? Can you all hear me?
Yes, sir.
Okay, right. So if you don't hear me, just send a message or thing. Otherwise, when you don't answer, I don't know whether you are there or you hear me. Okay, so this is what you see now. The one on the top on the left side, that is the normal thyroid. You see the vascularity. One on the right, the downwards, you see what you see in patients with Graves' disease. We call this do the color Doppler. That also some from your ultrasound scan. And is seen as a single nodule, and in thyroiditis, because gland is restricted, there won't be much of an increase in uptake, right? So thyroiditis, it's low. So you can differentiate like that. Right. So coming to the thyroid hormone production, and therefore, you can use the anti-thyroid drugs, radioactive iodine, and thyroidectomy. Those are the three main options available. And for the symptomatic treatment, I told you that cardiovascular effects will be prominent in these patients. You can use a beta blocker. You can use selective like propranolol, or patients, especially the eye complications, they could be sight-threatening. To prevent corneal ulceration, if the eyes are so prominent, you have to do lateral tarsorrhaphy, that's suturing of the two eyelids in the corners. And then orbital decompression is needed if there is compression of the optic nerve. Now, anti-thyroid drugs are generally the first-line therapy for Graves' disease. Having said that, in certain countries like USA, they prefer more towards radioactive iodine, but rest of the world, mostly, you treat with anti-thyroid drugs. And if you treat for the adequate period, that is about 1 to 2 years period, about 40% will go into remission. And the size of goiter, the theta the theta of the newer studies show that if you treat little longer than this, the remissions rate will be higher. Generally, we tend to limit our treatment period for 1 to 2 years because, as you know, anti-thyroid drugs do have side effects. So therefore, we don't like to go indefinitely with the treatment. But in certain patients where other modalities are contraindicated, a low dose anti-thyroid drugs for a prolonged period, even after 2 years, is a treatment option. But that you have to weigh the risk and benefit and decide. Generally, when you start with high dose and then you titrate down. It's quite different to the way you start thyroxine, where you start with the normal or low dose and increase, where here you start with the higher dose and come down. If you give more than 20 milligrams dose, generally we give in divide doses, but mostly if you give carbamazole, that's a once daily treatment because it has a long half-life, it concentrates in the thyroid gland, so therefore you can give once daily. But if you give more than 20 milligrams, generally, at least for the initial period, we divide it. That is mainly to get the effect a little more quickly And secondly, mostly it is because of GI side effects these medicines can cause. So till patients get used to that, you give it twice daily. Once we titrate down to 20 milligrams, then you can give it once daily. And once you titrate, your aim is to maintain T4 and T3 within the normal level. So those are the tests. T4 would be adequate. Is the test you be doing when you are following up the patients. And then you may have heard about block and replacement therapy of thyroxine. So what I've described so far is the titration regime. Block and replacement therapy, some centers, they use it. That is, you give a high dose of carbamazole along with thyroxine. And you continue with this high dose throughout for about 6 months period without reducing the dose. So invariably after about 1 or 2 months, patient will go into hypothyroidism that will be covered by thyroxine, which is added. So initial stage, you don't give thyroxine even in block and replacement. After about 2 months, you add thyroxine and you maintain the same carbamazole dose. So block and replacement, we don't use it that much because high dose of carbamazole is used, they tend to have more side effects. So therefore, we prefer the titration regime. And then block and replacement is contraindicated in pregnancy because high dose of carbamazole can cause fetal hypothyroidism. And carbamazole and methimazole is both available, and the other treatment is propylthiouracil. Can any one of you tell me what is the difference between carbamazole and methimazole? Yeah.
So methimazole has long half-life?
When you give carbamazole, what it is turned into in the body? How it is metabolized? So when you give carbamazole, it changes into methimazole in the body, right? So that methimazole is available as tablet. So you understand that is more potent than carbamazole, right? So dose-wise, if you are changing, methimazole is also available as treatment. If you give 20 milligrams of carbamazole, that is equivalent to 15 milligrams of methimazole. General starting doses are like 20 to 40 milligrams. There is no hard and fast rule to say what is the real starting dose. That depends on your T4 level. If it's about 1 to 1.5, we'll use to 10, and then about 2.5 to 3, we'll use 20, 30, and then about 40 to 60. So that's a rough guide only. You will only know what is the correct dose when you repeat the test and see how they are responding. But it will depend on the level of T4 to decide on treatment. So equal dose of propylthiouracil is 5 milligrams of carbamazole is equivalent to 50 milligrams of propylthiouracil. So it's a less potent one. It's again given as divided doses because it has a shorter half-life than carbamazole. So the mechanism I explained to you how these drugs act. Effects are only seen after at least about 2 weeks time. So till that time, you need to control symptoms. That's why we are giving a beta blocker, mainly to control these sympathetic symptoms. And then other side effects are they can get rashes, arthralgias, GI side effects are common. Then vasculitis, especially with PTU, liver function abnormalities. One of the main side effects is this liver failure with PTU, mostly with PTU. Carbamazole can also cause liver issues, that is mainly cholestatic type of jaundice. It's less severe than PTU. And then agranulocytosis can happen with both of treatment. So therefore, when you give these medicines, it's very important that you need to advise these patients, especially if they get fevers, sore throat, mouth ulcers, they need to come and report. We need to do the full blood counts and see whether there is any evidence of agranulocytosis. If that is the case, you stop the treatment and you cannot replace with other drug. If it's with the carbamazole, you can't give PTU if there is agranulocytosis. And then embryopathies are common with both drugs. Now you may have heard that PTU is the safer drugs. That's true. PTU causes less congenital abnormalities than carbamazole, but both can cause, even PTU can cause mild congenital issues. So therefore, what we prefer is to either, if possible, to go for a definitive treatment before pregnancy, or to control it well, so that they will be on a very low dose of these anti-thyroid drugs when they go for the pregnancy. So these patients should be advised to plan the pregnancy to avoid giving high doses within the first trimester of pregnancy. And not nodular toxic multinodular goiters, and then chance of remission will increase depending on the due fetus. Those patients will have higher chance of remission. And then when they are going for a definitive treatment like surgery or radioactive iodine, still then we need to control the thyroid symptoms before surgery. Otherwise, during the surgery or radioactive iodine, they can go into thyroid crisis, because when you manipulate the gland, sudden release of thyroid hormones can lead into thyroid crisis. So prevent that, you need to pre-treat them before the surgery and radioactive iodine. So before radioactive iodine, we generally stop 3 to 5 days before to maximize the radioiodine intake for that purpose. So once they settle, we reduce the dose. We maintain them on 5 to 10 milligrams, most patients. And then initially you have to do 4 to 6 weekly. And then the monitoring would be from T3 and T4. It's not TSH, because TSH will take time. If it's highly suppressed, it takes sometimes up to about 6 months to recover. So initial phase, you monitor by T4 and T3. And the period is about 12 to 24 years. So PTU, there is a warning that it was commonly now, unless for few situations. One thing is the first trimester thyroid storm situation, because it also inhibit, would be advantages in thyroid storm situation. And if the patients are intolerant to carbamazole and they can't go for any other treatment, then you can try PTU. Otherwise, it's always carbamazole in other patients. So these are the places where these drugs act. So all these things you have learned in your pharmacology, the endocrine module, etc. So we generally don't have any reliable method to stop these iodine transport in or production. Iodides will reduce the thyroid hormone release, and peripheral conversion is reduced by beta blockers, steroids, and the PTU. So these are the treatment options and the side effects. So important ones I have listed. So before using beta blockers, you have to make sure that there are no contraindications, especially if a patient is not asthmatic or COPD patient. And glucocorticoids we don't use in other situations. We only use in thyroid storm situation, where it's extreme severe levels of thyroid hormone elevation that seems to be reduced in the peripheral conversion. And then the supersaturated potassium iodides, where we get it as glucose iodine, they also inhibit thyroid hormone release, and quite a useful thing, especially Sanjeev will discuss. It's useful for surgical, before surgery, because it reduces vascularity. But you have to make sure that you give it to the effect and cause high elevation of thyroxine after for about 14 days. So you have to treat it for a shorter period, but it's a must in some patients, especially preparing for surgery. Now, what do you think this is? Have you seen this? Can anyone say what this is?
Alopecia cutis, sir.
Okay, so with what would you get this? What is the cause, do you think?
Carbimazole side effects, sir.
Yeah, so this is with carbimazole. As I said, the congenital effects are common with carbimazole. Yeah, it's more common with carbimazole than PTU. You rarely can get more severe congenital effects with carbimazole. That's what I said. We need to reduce the dose and give lowest possible dose to these patients with thyrotoxicosis planning pregnancy or pregnant should be managed in specialized centers. And then PTU has less congenital effect, but even with so radioactive iodine is a quite attractive option in Graves' disease, particularly because you don't need to do a surgery. Before radioactive iodine, you might have to give the beta blockers to control the cardiovascular symptoms, and then anti-thyroid drugs to control the thyrotoxic phase. Otherwise, with radioactive iodine, there could be a thyroiditis, which cause sudden exaggeration of the sudden elevation of the thyroid functions, which would lead to other problems. But before radioactive iodine, you stop the anti-thyroid drugs for 3 to 5 days, so that will maximize the radioiodine uptake to the gland. And one problem with radioactive iodine is it worsens the orbitopathy. So if the patient has moderate to severe thyroid eye disease, this may not be the best option. Then you have to think about surgery as a suitable option. Pregnancy is absolutely contraindication. So if a patient has undergone radioactive iodine therapy, you have to wait for about 6 months before pregnancy. And the Graves' disease, you calculate a dose based on patient's levels of hypothyroidism and the weight, give a fixed dose to ablate the function of most of the thyroid producing cells. Most patients after Graves' disease will eventually go into hypothyroidism. And it's less so common with toxic multinodular goiters and toxic adenomas, because in those situations, only the nodules will take up the iodine and they will get destroyed. But in Graves' disease, all of the gland will take up iodine and they get destroyed. So eventually most patients after Graves will turn into hyperthyroid and they need thyroxine replacement. Very rarely first dose patients will fail with the first dose. So you might have to use a second dose. And then after radioactive iodine, you need to follow certain precautions. You have to be in a separate rooms. If there are children, you should not come in contact for a few weeks like that. If only patient can fulfill those requirements, they are suitable for radioactive iodine. And bit about this Graves' orbitopathy. If it is mild, you can still use radioactive iodine in these patients. If it is moderate to severe, especially active things, you have to do the anti-thyroid drugs and you have to give them high-dose steroid course. And radioactive iodine may not be the suitable treatment. If it is inactive, you can do the radioactive iodine to control hypothyroidism after anti-thyroid drugs if it fails. And then you need rehabilitative surgery to correct the inactive severe eye disease. If it is side-threatening, again, you do anti-thyroid drugs, give the glucocorticoids, IV glucocorticoids, and then do the orbital decompression to save the vision. So that's the path we follow when there is orbitopathy. And finally, the threatening or life-threatening situation with hypothyroidism is thyrotoxic crisis, which we also called as thyroid storm. It's the high levels of thyroxine in the blood. The precipitating causes are the infections, extreme stress, diabetic ketoacidosis, trauma, toxemia with any other agents, manipulation of the gland when it is not, the hypothyroidism is not controlled. So these patients are having extreme features of hypothyroidism, tachycardia, cardiac dysrhythmias, chest pains, vomiting, hypothermia, and due to high catabolic state, and they are extremely restless and agitated. They may be in delirium as well. So you do the thyroid functions, you confirm the diagnosis, and then you do the medical management. So anti-thyroid drugs, the preferred one will be PTU. So other countries, they have intravenous thyroid medicines. they give that, but here we have the oral ones. So we give through the nasogastric tube, you give the PTU. You need to give high doses more frequently, up to about 200 milligrams every 8 to 6 hourly. And then you need to give IV corticosteroids as well, because of the increased metabolism. There is increased destruction of steroid hormones. For that, you need to give IV hydrocortisone. And then glucosidine can be given to quickly control the thyrotoxic state for temporary period. Beta blockers is a must to control the cardiovascular effects. So hydrocortisone I mentioned. And then you need IV fluids and symptomatic management for the fever. So these patients have been monitored, their vital signs. You can do external things like cooling and other things for the hypothermia. Right. So I think that is the important part in the medical management, because I need to go in a little while. I'll answer any questions if you have. That's okay, Sanjay, isn't it?
Yeah. Yes, sir. No problem.
If you have any questions, you can ask me.
Sir, why does the radio iodine therapy increases the orbitopathy, sir?
I'm also not sure about the exact pathophysiology. Maybe, but it is a well-known complication when you give radioactive iodine in severe eye disease. One thing is, as I can vaguely remember, it increases the TRAB levels. So you see after radioactive iodine, you see increase in TRAB levels. So that may be that will definitely increase the pathophysiological things, so which will increase the eye problem. So that is one proposed mechanism why they say it will increase eye disease.
Thank you.
Any other questions? Okay, so if you don't have any questions, I'll give it to Prof. Sanjeev. He will continue from there.
Okay, thanks, Ajit. Can you make me the host, Sajid?
You are the host now.
Thanks. Okay, right. Can you all hear me?
Yes, sir.
You all want a break? Now you all have been listening for a long time. Shall we have a 2 minutes break? If you want, you can stretch yourselves and come back. Okay. In the meantime, do you all have any other questions to ask?
ඔයා දඟලනවනේ අනේ හරිය.
Okay, can we start now?
Yes, sir.
Okay, right now, just to recap what Sachit had been discussing, he discussed about Graves' disease, what it is about, the pathophysiology, then different treatment options. He discussed about medical management, then bit about radioactive iodine treatment as well. And then surgery is always considered as an option in the management of Graves' disease. So it is not the primary modality of treatment, although some people consider early surgery as an option, but traditionally or commonly surgery is not used as the primary treatment modality, but as a secondary or a definitive treatment modality in patients who do not respond to surgery plus or minus radioactive iodine therapy. So I have given here some of the indications for thyroidectomy in patients with Graves. This is a surgical removal of the thyroid. For example, one condition is drug resistance. Some patients with medical managed therapy, that is with carbimazole or propylthiouracil, are failed to control. Such situations, we may consider surgery. And also, Sajid mentioned that generally we treat them with medical management for 1 to 2 years, and after that time duration, the chance of complete resolution or a cure is unlikely. Therefore, if the patient is not cured after that duration of treatment, again we consider one option or definitive treatment option is surgery. Significant side effects, he discussed about the side effects of anti-thyroid drug or severe eye disease. If the patient has a large goiter or suspicion of malignancy, then obviously surgery becomes the definitive treatment modality. Some people, of course, do not like radiotherapy. Then again, we can offer them a total thyroidectomy. The advantages are you remove the thyroid, we remove the thyroid completely, so the disease will be completely cured. Immediate definitive treatment, they will never ever get Graves' disease. It's definitely cured, but of course at the same time there is a price to pay. Somebody has to undergo thyroidectomy. The patient has to undergo thyroidectomy, and which is associated potential complications. Plus, they will have to be on lifelong thyroxine after surgery. So the complications of surgery include, the standard ones, including recurrent laryngeal nerve palsy, hypoparathyroidism. But in addition, in patients with hyperthyroidism, like Graves' disease, there is a risk of excessive bleeding because the gland, Sachit showed you those pictures, colored Doppler images where the gland was highly vascular. Therefore, there's a risk of bleeding during surgery more than a standard thyroidectomy. Plus, he mentioned about the risk of thyroid storm or thyroid crisis, which happens due to excessive release of thyroxine into the circulation during surgery. However, it is a very rare complication nowadays because we almost always completely control the thyroid status prior to surgery with anti-thyroid medication and sometimes with additional beta blockers. So combination generally helps us to make almost all patients euthyroid prior to surgery. The risk of thyroid crisis becomes very small. In addition to that, glucosidine is another option, although we don't use it much often these days. Right. So that is about the management of Graves' disease. So in summary, Graves' disease primarily is a medical problem due to receptor antibodies. Once the diagnosis is confirmed, standard management includes antithyroid medication, initially a loading dose or a high dose, subsequently a maintenance dose, which is continued to 1 to 2 years. And then if the patient doesn't respond or is not cured after that, or if there are other indications, then we may go for second line treatments, which include radioactive iodine or surgery. In summary, that is the management of a Graves' disease. On the other hand, toxic multinodular goitis is quite different. It is not an autoimmune condition like Graves' disease. Here, the thing what happens in toxic multinodular goitis is, now, this is a multinodular goiter that has been there for a long time, typically a couple of decades. So, in a multinodular goiter, what happens is there are these follicles which undergo hyperfunctioning, involution, etc., repeatedly, and that may lead to the formation of autonomous cells which are no longer under the regulation of TSH. So, without the presence of TSH, these cells are capable of secreting thyroxine. This condition is also known as secondary thyrotoxicosis or plumber's disease, and it is directly related to the incidence of goiter, multinodular goiters in a country. You may be aware that in Sri Lanka, the incidence of multinodular goiter is quite high, especially this part of the world, South Asia and Southeast Asia. It's a very common problem as compared to the West. For example, there are studies which have been conducted in Sri Lanka, population-based studies, where they have documented that about 8% of adults in Sri Lanka do have a multinodular goiter. Since toxic multinodular goiters are directly related to the incidence of goiters, it is the commonest cause of toxicity or hyperthyroidism in Sri Lanka, and not Graves' disease like mentioned in your books which are written in the West. Of course, in the West, it's Graves' disease, but in Sri Lanka, it's toxic multinodular goiter. Remember that. It far exceeds the number of patients with Graves' disease that we see. So pathophysiology, we have gone through it briefly. There are variable growth of these individual nodules. Earlier, people thought this was due to iodine deficiency, but there is no longer any iodine deficiency in Sri Lanka. Yesterday, we had a discussion. Some of the students didn't agree with me. But there are, again, Sri Lankan studies. I'll show you one study where they have documented excess iodine in our body now because we are using only iodized salt. So this, if you want, you can access this article online. It's freely available. Iodine deficiency status in Sri Lanka, a national survey conducted in 2016. I will just show you the concluding statement of this document. So what they say is, last sentence, 15-16, all provinces as well as the national level data indicated more than adequate iodine levels, which is a matter of concern. So in fact, we have much greater amounts of iodine in our body than we require because of excessive salt iodination. So some people believe that is a cause for excessive numbers of patients with thyroiditis in Sri Lanka. But it is not proven, but that is just a hypothesis only. But what we know is, based on the evidence, we have more than iodine than we need. So there is no iodine deficiency whatsoever in Sri Lanka, any part of the country. So some people still believe Kaluthura and Ratnapura there is iodine deficiency. No. Over the last 20-25 years, we have been using iodized salt. Therefore, there is no iodine deficiency in Sri Lanka whatsoever. Okay, so coming back to toxic multinodular goiters, how do they present? They will present features of hyperthyroidism with a goiter. Presentation is slightly different. The typical age group is slightly older than the young females who present with Graves' disease. Here, it's a middle-aged man or a woman, again common in females, present with the goiter and features of hyperthyroidism, but it's little different from Graves' disease. Eye signs are, of course, not there, other than lid lag and lid retraction due to excessive sympathetic activation of levator palpebral superioris muscle. They are more likely to have cardiac problems because this is an older group of people. They tend to present more with atrial fibrillation and features of cardiac failure. In addition to that, older people, like above 70, sometimes they have features of hypothyroidism. They are very apathetic and lethargic, etc. Therefore, that is called apathetic hyperthyroidism. So that is another presentation. Toxic multinodular goiters, what do we do? Once we have a clinical suspicion, we do TSH and T4 levels to confirm the severity and confirm the diagnosis and assess severity. Ultrasound scan is routinely done, unlike in Graves' disease, to identify the nodules and to check whether there are any nodules with features suspicious of malignancy. If we see such nodules, then we do FNAC. Uptake scan is not indicated unless we have a doubt whether this is a thyroiditis or a toxic multinodular goiter, where the uptake is increased, whereas in thyroiditis, the uptake will be reduced. So it is not done unless we have a serious doubt about the diagnosis. Or else if you have a doubt, other option is to wait for a couple of months. In thyroiditis, it should come back to normal, whereas in high toxic multinodular goiter, it will continue. Right. So once the diagnosis is confirmed, that is a patient with a multinodular goiter and toxicosis, initial management again is anti-thyroid medication. We control them with anti-thyroid drugs plus or minus beta blockers. However, there is no place for continued medical management for years, unlike in Graves' disease. So Graves' disease, we know since it is autoimmune, there's a significant proportion of people going into complete remission. Here, it's just autonomous cells producing thyroxine. Therefore, anti-thyroid medication will control the disease, but will never cure the disease. So they will have to be on, if at all, they should be on lifelong anti-thyroid medications. Such it mentioned, if you again just to reiterate, these drugs are associated with serious side effects. Plus, there is a thing called carbamazole resistance that these patients may develop after a few years of carbamazole treatment. So to prevent all that, we always go for a definitive treatment for these patients. We don't wait for years. As soon as the patient is controlled, we offer them either a total thyroidectomy or radioiodine therapy as a definitive treatment modality. So once the patient is medically controlled, we offer one of these treatments. In general, for these patients, surgery is preferred because one reason, they have a multinodular goiter, plus the response rate is probably not as good as with Graves' disease where the uptake is high. But having said that, risk of hypothyroidism is low in these patients after radioactive iodine therapy because uptake again is less. So considering everything, whether the patient likes to undergo surgery, the size of the goiter, other symptoms, cosmesis, everything, we decide on the final treatment of option for the patient. So both are options. Surgery, of course, like in Graves' disease, will give you 100% cure, but at the cost of potential complications. Radioactive iodine therapy may not work 100%, less efficacious, but will avoid an operation with potential associated complications. So we consider everything and decide on the final treatment modality. Right, so that's about toxic multinodular goiter. So the presentation is a multinodular goiter with toxicosis. Diagnosis other than T4 TSH, we do ultrasound scan, plus or minus FNAC if we see any suspicious nodules. Then the management is initial medical followed by always either surgery or radioactive iodine therapy. If you have any questions, you can ask either through chat or you can directly stop me and ask. Okay, so we have discussed two conditions leading to hyperthyroidism. That's Graves' disease and toxic multinodular goiter. Then third one is toxic nodule or toxic adenoma. This is a patient who presents with features of hyperthyroidism with a solitary nodule in the thyroid. The pathology of pathophysiology here is there's an adenoma in the thyroid producing excessive amounts of thyroxine, leading to hyperthyroidism. Management pretty much is the same. The confirmation, initially TSH, T4 to confirm the hyperthyroidism. Ultrasound scan will confirm there is a solitary nodule. If the ultrasound scan shows features to suggest or suspect malignancy, then we go ahead and do a FNAC. However, we know very rarely only these lesions are malignant. Hyperthyroidism with malignancy is a very rare association. However, there's another important investigation that we do, that is uptake scan or scintigraphy. It is considered essential in this situation because it is the only investigation that will tell us that this is a toxic adenoma. Everything else is circumstantial only. Somebody with a solitary nodule toxicosis, it could be something else. So only a uptake scan will tell us and confirm that this is a toxic adenoma. This is a picture of uptake scan. You see patient has a nodule on the left side of the neck. Exactly where the nodule is, there is an increased uptake. So this will confirm that this is the nodule or the culprit. It is important because, especially if you are going to offer her surgery, so hemithyroidectomy is going to be curative in this situation because right lobe is completely normal. It's a benign problem. Once you remove the lobe, patient is going to be cured for life. Not so much important if you are going to give radioactive iodine therapy. So radioiodine is one option. This is a toxic nodule. Most of the iodine will be taken up by the nodule. Therefore, longer-term hypothyroid risk is low. But again, like every condition, there is hyperthyroidism. Radioactive iodine has a limited efficacy as compared to surgery. When it comes to surgery, we can offer patient an ipsilateral lobectomy, that is hemithyroidectomy. We preserve the opposite side. So that's about toxic multinodular goiters. Then the next situation is, now we have discussed the three conditions that lead to hyperthyroidism. That's Graves' disease, toxic multinodular goiters, and toxic adenomas and their Okay, sorry for the disruption. I had to answer a call. Right, coming back to multinodular goiters, it's now earlier also I mentioned the fact that this is a very common problem in Sri Lanka. All of you would have seen hundreds and hundreds of multinodular goiters. There are so many explanations, but none really explains why it is so common in Sri Lanka. Earlier, people thought or people used to think that this was due to iodine excess, but now, as we discussed previously, we know there is no iodine deficiency in the country, but still we find this to be a fairly common problem. So there are other theories, including genetic or familial, various other theories, but none have been proven. Right. Pathology is again multiple factors leading to variable growth of individual follicles. That is all that we know. Early we thought this was due to iodine deficiency, but apparently it is not so. So what happens is that this may progress to hemorrhage and degeneration, various other problems like healing, fibrosis, finally leading to multiple nodule formation, or what we call a multinodular goiter. So when somebody comes with the presence of the multinodular goiter, what do? We need to assess clinically the size, extent, whether they have compression symptoms, as well as whether there is a retrosternal extension, because these are the things that things that are important for our management. Also, we need to check with the patient whether the patient has any cosmetic concerns regarding the goiter. Then once after the clinical assessment, we need to do a radiological assessment, which includes ultrasound scan, essentially again to look for any nodules which features suspicious of malignancy. X-ray of the neck we may do, not essential if we are suspecting in tracheal deviation or compression. FNAC is limited to suspicious nodules. No point in doing a blind FNAC in these patients who have got multiple nodules. A TSH alone is enough to confirm the thyroid status. CT scan is reserved for situations where there is retrosternal extension, because otherwise we cannot assess the status of the thyroid inside the chest. So after that, indications of surgery in multinodular goiters. Toxic multinodular goiter is one, we have already discussed that. So the other indications include features or signs and symptoms of compression. If the patient has either things like recumbent dyspnea, or you find the trachea to be deviated significantly, or trachea is compressed, then those patients we may offer surgery. Plus, retrosternal extension is another indication for surgery, because these patients, one thing we know, they are at a higher risk of developing complications or compression symptoms. In addition to that, the assessment of the thyroid is difficult in these patients, because the segment that is inside the chest cannot be followed up without a CT scan every year. So this is not feasible. We know they are at a high risk of developing complications. Therefore, we offer them surgery. That's a definite indication for surgery. Other indication surgery in multinodular goiter is cosmesis. If the patient doesn't like the appearance of the goiter, then we can offer surgery. Other than that, just the presence of a multinodular goiter is not an indication for surgery. So multinodular goiters, how do we treat? Surgery is only treatment. There are no other treatment modalities that are effective. Total thyroidectomy, where we remove the whole gland, is the the standard treatment. Very rarely only one side would be affected, in which case we can offer them a hemithyroidectomy or lobectomy. A lot of people, if you might have seen, especially general practitioners, start these patients around thyroxine, thinking that the multinodular goiter is due to lack of thyroxine in their body. Not so. Thyroxine has no place in the management, and there are studies which have shown no benefit in giving thyroxine to these patients unless they are hypothyroid. Radioiodine, okay, it may lead, here remember the word may, not always, may lead to partial regression. So we may offer surgery, radioactive iodine for a patient who doesn't want to undergo surgery with a large or symptomatic multinodular goiter, or patients with recurrent goiters after previous operations where the risk of damage to recurrent laryngeal nerve is high. But the resolution, because most of these nodules are filled with colloid, so the size of the nodule very unlikely to go down significantly with any of these treatments other than surgery. So surgery is only definitive treatment for a multinodular goiter. Okay, so that's about multinodular goiters. Nothing very much how they present, the reason, but the pathophysiology and the complications they develop and indications of surgery. Surgery is only definitive indications of is the definitive intervention. Any questions about multinodular goiters? Before we move into the last topic or last couple of topics. Right, okay, we'll move into the next topic, that is thyroid neoplasms. It's a common problem, very common problem in Sri Lanka, thyroid malignancies. Its numbers are going up like nothing. You know, a few years ago, these were quite not so common, but now it has become the second commonest cancer in Sri Lankan females. Breast is the highest, second is thyroid. So it has gone up so fast over last several years. This graph is from 2008, now the 2015 data. Thyroid is the second commonest malignancy. So this is the broad classification of thyroid malignancy. There are primary and secondary. Secondaries are rare. Primary ones either may occur from follicular or rise from follicular cells or parafollicular cells, or rarely from lymphoid cells which are inside the thyroid. So follicular cells, if they are differentiated, they are either papillary or follicular. Undifferentiated is called anaplastic carcinoma, which is a very, very aggressive lethal carcinoma. Then if the tumor arises from parafollicular cells, they are called medullary. If they come from lymphoid cells, they are called lymphomas. These are the common types of thyroid malignancies that we see. There are so many different etiological factors that are described. For example, radiation exposure. It's well proven, for example, in areas like Chernobyl, Bhopal, papillary carcinomas are very common. Especially Chernobyl, it is. I mean, the reports say more than 10 to 15% of the people have gone on to develop papillary thyroid carcinomas. Same in areas like Hiroshima and Nagasaki subsequent to those nuclear explosions. So radiation exposure is one of the most common risk factors for development of papillary carcinomas. Long-standing chronic thyroiditis is also a risk factor for development of both lymphomas and papillary carcinomas. Long-standing multinodular goiters are associated with follicular carcinomas of the thyroid, but the associated risk is quite low. Then you get into the medullary, genetically inherited malignancies. Medullary carcinomas, there are conditions, for example, familial medullary carcinoma syndrome or multiple endocrine neoplasia syndrome. So there are various conditions that are associated with different types of thyroid malignancies. So how do they present? The commonest presentation is a nodule in the thyroid, a solitary nodule or recent onset solitary nodule. Sometimes in addition to that, they may present with lateral lymph nodes, cervical lymph nodes, especially with papillary carcinoma of the thyroid. Plus the change in voice is a possibility in advanced papillary carcinoma invading the recurrent laryngeal nerve. Pain radiating to the nerve ear is another rare presentation that is due to infiltration of the vagus nerve. So this happens only with an advanced malignancy. Sometimes they present with pathological fractures, for example, spinal fracture or a long bone fracture or a lump in the scalp or skull due to bone metastasis arising from follicular carcinomas of the thyroid. Those presentations are commonest. More than 95% of the time what we see is a solitary nodule of the thyroid. Okay, coming into malignancies, papillary carcinoma is the commonest variety, but they have one of the best prognosis among all malignancies with a 10-year survival. We are not talking about 5 years survival of papillary carcinomas. The 10-year survival of over 95%. Multifocality is common, that is both sides may be involved. Histology, would have learned all these things in your pathology. There are the classic features, including papillary structures, open any nuclei, and bodies. All these are seen in papillary carcinoma. Unlike other malignancies, they spread quite early to lymph nodes. Even today, we did a thyroidectomy for a papillary carcinoma where the lymph nodes were involved. So where we had to remove the lymph nodes. This is a fairly common thing in papillary carcinomas. Sometimes the primary tumor in thyroid may be small, while they present with large lateral cervical lymph nodes from the papillary carcinoma. So earlier people used to call this lateral aberrant thyroid because everything, even the FNAC, is suggestive of normal thyroid tissue. These lymph nodes resemble normal thyroid tissue because they are now replaced with differentiated thyroid carcinomas. So this is a misnomer. It is not aberrant thyroid, it's a papillary carcinoma deposits in lymph nodes. This term is no longer used. They have excellent prognosis, but these are some of the factors that determine prognosis, including age. Yesterday also I discussed with the group who were doing the appointment with us, young age. Your age is the best commonest age group, at the same time the best age group to get a papillary carcinoma of the thyroid, because 99% of the time you will be cured, irrespective, even if you present with metastatic disease. Other factors that determine prognosis include size, metastasis, invasion, and whether we have been able to remove it completely surgically. Right, so these are some of the pictures. Right, moving from papillary to follicular, it's slightly different. Now the papillary carcinomas are diagnosed with FNAC, whereas follicular carcinomas we cannot diagnose with a FNAC because FNA can say that this is only a lesion rather than a follicular carcinoma. So when the FNAC suggests a follicular lesion, neoplasm, that is classification Thy3F or Bethesda classification Bethesda 4, what we do is we go ahead and do a diagnostic hemithyroidectomy. There are the pathologists, once we remove the specimen to see whether there is any evidence of capsular or vascular invasion. If those are there, then they will report this as a follicular carcinoma, in which case we have to go ahead and remove the opposite, which will enable us to give the adjuvant therapies, including radioactive iodine therapy. So this is a picture of a capsule invasion. You can see there's a nice capsule around this lesion, but at one point the capsule is invaded by the follicular cells. So this is what the pathologist will look at and say, okay, this is not a follicular adenoma, but a follicular carcinoma. So that is because this cannot be seen with the FNAC. It can be seen only after removal of the ipsilateral lobe with the lesion. So that is why we have to do a diagnostic hemithyroidectomy in these patients. So how do we treat these differentiated thyroid carcinomas? Treatment of both follicular and papillary carcinomas are quite similar. We do a total thyroidectomy commonly unless the lesion is very small. Additionally, we may remove lymph nodes in papillary carcinomas, the nodes that are involved. So once the gland is removed, how do we treat? We give them radioactive iodine to mop up any remaining malignant cells. So radioactive iodine will be taken up by any remaining malignant cells after removal of the thyroid, and therefore that is one of the reasons why these patients have such a good prognosis. In addition to that, we keep them on supraphysiological doses of thyroxine, or what you call TSH suppression therapy. Thereby we keep TSH at a very low level, because these are differentiated thyroid carcinomas which are dependent on TSH for their growth and replication. By keeping TSH at a very low level, we can reduce the risk of tumor recurrence. So after radioactive iodine therapy and thyroxine suppression, we follow these patients up with maybe annual ultrasound scan to look for a recurrence in the neck, and thyroglobulin levels, which is a very, very useful tumor marker, because there we have removed the thyroid gland completely, and their thyroglobulin should be undetectable in these patients, because there is no thyroid. If it starts rising, then we know the patient is getting a recurrence. This is just a little bit about post-operative iodine ablation. So after the removal of the gland, we give this radioactive iodine therapy for patients who are at a risk of developing a recurrence for papillary and follicular carcinomas, of course. Indications very young or very old, or almost always we give, they have advanced disease including metastasis, large tumors, nodal or the indications. Anyway, these will be decided by the oncologist. TSH suppression therapy, I have already mentioned that here we try to keep TSH at a lower level because that is the stimulation for the growth and recurrence of these tumors. Tumors, I briefly mentioned at the beginning, this is one of the most lethal known malignancies to humans. So hardly anybody would ever survive anaplastic carcinoma of the thyroid. Generally, once an anaplastic carcinoma is diagnosed, we don't try to do anything. Whatever we do, they are dead within a month. They essentially grow within few days. Looking at the tumor, they grow so fast and penetrate all the structures, airway compression, airway obstruction, and then the patient would be dead within a few days to few months. There is art in that we can do. Moving on from now, we have discussed malignancies arising from follicular cells. Now, these are the next malignancy arising from parafollicular cells. Here, the malignancy is called medullary carcinoma of the thyroid. They arise from parafollicular cells. Presentation is pretty much similar with the thyroid nodule. In addition to that, they may have features due to high secretion of serotonin and prostaglandins, for example, diarrhea. There are different ones we have briefly mentioned already, like familial medullary carcinoma syndromes and multiple endocrine neoplasia associated syndromes, that is type 2A and 2B. In addition to that, there are sporadic medullary carcinomas as well. I have mentioned follicular carcinoma spread via blood-borne or hematogenous. This tend to spread via both routes. And it is generally more aggressive than the differentiated thyroid cancer. So our treatment is also more aggressive. These patients generally get a total thyroidectomy plus lymph node dissection even when the nodes are involved. Other problem about these malignancies is they are not responsive to any of the adjuvant therapies that are available. They don't respond to radioactive iodine therapy because they are not arising from follicular thyroid cells, and they don't respond to either chemotherapy or radiotherapy. So surgery is the only effective treatment modality available for those patients. I have already mentioned about the prognosis, generally excellent prognosis. Thyroid cancers, differentiated thyroid cancers, extremely good prognosis, or 90-95%. Biliary not so good. It's slightly worse than papillaries. Anaplastic, that's the worst known human malignancy to humans that we see in general practice. Okay, so they have very poor prognosis. Moving on from malignancies to thyroiditis. Thyroiditis is inflammation of the thyroid gland. There are three varieties of thyroiditis that we talk about: acute, subacute, and chronic. Acute thyroiditis is generally a rare problem associated with infections of the thyroid gland. What we see more commonly are the subacute or decurvent thyroiditis and chronic thyroiditis or Hashimoto's thyroiditis. This typically present with a goiter, pain due to the inflammation. Either they are either thyrotoxic or hypothyroid, depending on the state that we see them. Subacute thyroiditis typically follows a viral infection. The typical patient come and tell us that they had a viral infection a couple of weeks ago with upper respiratory tract symptoms and a fever. Now they have painful swallowing and pain in odynophagia and the common presentations in these patients. In addition to that, some of them have a low-grade fever. Examination, we find a tender goiter, and investigations will show that their white cells and CRPs are elevated, TSH levels are low, T4 levels are high. I have not mentioned here, they have features of hyperthyroidism at presentation, subacute thyroiditis. They present with features of hyperthyroidism in addition to the goiter and odynophagia. So once you confirm that this is a subacute thyroiditis, we don't start them on any anti-thyroid drugs because it's a thyroiditis. There is no excessive secretion from the gland. It's a self-limiting condition which will go into a complete resolution within a few months to few weeks. So we just treat them with NSAIDs, which helps with inflammation and pain, and rarely or sometimes steroids to control the inflammation. Otherwise, there is no place for anti-thyroid medication in patients with subacute thyroiditis. It's a self-limiting post-infective condition. More common condition, or the commonest form of thyroiditis that we see is Hashimoto's or chronic lymphocytic thyroiditis, which is extremely common in Sri Lanka. Some people believe this is due to excessive iodine uptake in our country. So commonly we see this in young females starting from maybe 20s going up to 30, 40 years. There is autoimmune destruction of the thyroid gland due to this chronic inflammation, leading to gradual development of hypothyroidism. I know there are a lot of even medical students in our faculty who are hypothyroid due to this Hashimoto, so chronic thyroiditis. It's a very, very common problem. So the only thing is their goiters are not that big. Sometimes it's not visible even. It's a tiny goiter, rubbery, typical rubbery consistency. Presentation is mostly with features of hypothyroidism. Management, if they present with the goiter, we do ultrasound scan and FNAC is confirmatory. FNAC will confirm that this is thyroiditis. In addition to that, if you want, we can do TPO, thyroid peroxidase level. And then we follow these patients up with TSH if they are not already hypothyroid. If they are already hypothyroid, we start them on thyroxine. Otherwise, we follow them up with annual TSH levels to detect them when they develop hypothyroidism, to start them on thyroxine treatment. Vast majority of them end up with hypothyroidism. Okay, there is a question somebody had asked whether there's a place of beta blockers in patients with subacute thyroiditis. Yes, sometimes we do, because these patients may present with features. I told you they have features of hyperthyroidism. There's no place to start them on anti-thyroid drugs because there is no increased production. Therefore, just to control symptoms, we may give them a short course of beta blockers in addition to NSAIDs. Yes, we do. Right. So coming back to thyroiditis, it's the most common form of thyroiditis is Hashimoto's. The problem there is long-term hypothyroidism. So other, except for that, others, that is acute and subacute, they have a they resolve automatically. So there is nothing, no long-term effects. Okay, that's about it. Then we can, go through the conditions that we discussed at the beginning and answer the questions. So if there are any questions from what we have discussed, whatever I have mentioned or what Sajid had mentioned to you, I'm happy to answer them now. You can either ask or you can use the chat. Okay, somebody had asked, how do we stage a thyroid carcinoma? Okay, differentiated thyroid carcinomas. We do ultrasound scan unless there are palpable or enlarged nodes. We don't do any further staging. So we assume that papillary carcinoma would spread from the thyroid to the neck lymph nodes and from there beyond. That happens quite rarely again. So if the nodes are not involved, we don't do any further staging. But if the nodes are involved, we may do a CT scan to look for the spread of the disease. But still, the primary treatment doesn't change. Primary treatment would be surgery, thyroidectomy plus or minus removal of lymph nodes. So CT scan should not delay further treatment. So then there's another question. Is there a place for co-biopsies in thyroid carcinoma or thyroid? Yes, certainly we do. There are a couple of definite indications. One is if you're suspecting anaplastic carcinoma, to histologically confirm, we may do a co-biopsy, because I told you there is no place for removing the gland, and FNAC alone cannot confirm the diagnosis. Another one is thyroid lymphoma, where again there is no place for thyroidectomy. Management is medical chemotherapy. So to confirm and subtype the lymphoma, we may do a co-biopsy. So those two are the definite indications. But beyond that, whenever we have a diagnostic difficulty, we may do, not essential, we may do a co-biopsy. But the problem, people are scared to do the co-biopsies of the thyroid because it's highly vascular. There are so many other vital structures around the thyroid. So unless it's a place where they routinely do co-biopsies, people are a bit reluctant to do. But certainly there is a place. Any other questions? Okay. So we'll go into the first case scenario, the Graves' disease. So young girl with features of Graves' disease, how should be further evaluated and treated? Since there is no diagnostic doubt here, and she is not pregnant also, Thyroid trap antibodies are not essential in this situation to confirm the diagnosis or to manage. Some people might do, but not essential. We will start on anti-thyroid drugs, that is carbimazole with propranolol. And once she becomes euthyroid, we can just continue the carbimazole maintenance dose for a duration of 1 to 2 years. Then we would stop it. And if she doesn't get a recurrence, that means she is cured. That's the end of the story. But if she gets a recurrence, then she needs to go for definite second line treatment, that is either surgery or radioactive iodine therapy. But that's a standard pathway. Of course, there would be exceptions. For example, if she has severe eye disease, we'll have to manage the eye disease. If she develops complications or side effects due to medication, then there are other possible things that we might have to do. But beyond that, the standard management would be medication for 1 to 2 years. If she's cured, that's the end of the story. But if not, she has to go for either surgery or radioactive iodine treatment. Next on the toxic multinodular goiter management is we start the patient with anti-thyroid medications. So once the patient is controlled, we offer him either surgery or radioactive iodine therapy. Fairly straightforward management. Third one is the multinodular goiter, euthyroid, no compressive symptoms, no recent rapid enlargement, no change in voice. So unless the patient is concerned cosmetically, we don't have to do anything. We can just leave it and follow up. Initially, maybe in 1 year's time, ultrasound scan. If there's no change in size or symptoms, we can see her every couple of years. That's all that we need to do. There's no place for surgery unless either patient is symptomatic or cosmetically concerned. This is the 42-year-old with a solitary nodule. So we need to assess the nodule ultrasonically to see whether there are any features suggestive of malignancy. Plus, we have to assess the lymph node status, then FNAC of the nodule to check whether it's a malignancy, and if it comes as malignancy, a total thyroidectomy followed by radioactive iodine therapy, thyroxine TSH suppression, and thyroglobulin follow-up. Okay, so we'll go into the case scenarios. So first one is a 50-year-old female undergoes a total thyroidectomy for carcinoma. List 4 possible causes of postoperative upper airway obstruction that may occur in this patient. Then second one is explain the pathophysiology of each complication listed. Outline the treatment of one of the complications. So can somebody answer? Fairly straightforward question. Yes? Anybody? Okay, so if you are not interested, I think we can stop and finish it off.
So the 4 possible causes are bilateral recurrent laryngeal nerve palsy, hematoma formation due to reactionary bleeding, hypocalcemia, and tongue falling backwards because of the effects of general anesthesia.
Post-op papaya obstruction, but that is not specific, no? For this,
yes, sir.
That can happen in any patient. Is there any other condition that is specific for thyroidectomy?
Tracheomalacia.
Yeah, tracheomalacia is another one. Yes, good. So those are the likely 4 causes. Then what happens in each of those conditions? First one, recurrent laryngeal nerve palsy, what happens?
The recurrent laryngeal nerve is the one that supplies the posterior clitoris, which is the only abductor of the vocal cords. When
adductor, what supplies adductors?
Superior.
If you cut both recurrent laryngeal nerves, what is going to be the position of the recurrent laryngeal, the vocal cords? Abducted or adducted?
It is in the neutral positions.
Yeah, cadaveric. So that is because both the abductors and adductors are supplied by the recurrent laryngeal nerve, not only the abductors.
But the peripheral part of the recurrent nerve.
Yeah. So in addition to that, there are adductors which are supplied by another nerve, right? But recurrent laryngeal nerve supplies both abductors and adductors. Okay, so if you cut both of them, it will be in the cadaveric position. The airway may not be adequate for the patient to breathe. Right? That is why the patient would develop stridor. Right? That is recurrent laryngeal nerve palsy. Then what the next one? Hematoma. What happens in hematoma?
So once the hematoma forms, it forms deep to the deep fascia, and it is a constricted space where the pressure will be going up drastically, and this compresses the venous system, which leads to back pressure and laryngeal edema.
Yeah. Okay. Then what is the third one? Hypocalcemia.
So hypocalcemia causes laryngeal spasms, which leads to stridor.
So hypocalcemia will increase the muscle excitability. You have learned that during your physiology in the first year. So then the patient can develop muscle spasms. However, laryngeal spasms are quite rare. They get carpopedial spasms. Laryngeal spasms are rare, but it's described. I have not seen it. Then the fourth one is tracheomalacia. Why do people get tracheomalacia?
During long-standing thyroid goiters, there is softening of the tracheal rings, and due to sudden removal of thyroid gland, there's a sudden loss of support to the trachea by that also. Because of those two reasons, there is tracheal collapse.
Yeah. So what happens is long-standing multinodular goiter, there will be atrophy of tracheal cartilages due to pressure atrophy. So the patency of the trachea in those patients is supported by the presence of the thyroid. So once the thyroid is removed, there is a risk of the trachea collapsing completely, causing upper airway obstruction. Right. So all four are described here. So recurrent laryngeal nerve palsy, bleeding, causing increase in pressure inside the pretracheal fascia, causing venous obstruction, leading to laryngeal edema. Laryngeal edema is the most important reason leading to upper airway obstruction in this patient. Then hypocalcemia due to hypoparathyroidism, increased muscle excitability, causing laryngeal spasm. Now you have described pathophysiology, so all these steps have to be there in your answer if you are describing pathophysiology. You can't just say hypocalcemia leading to laryngeal spasm. So better to say it is due to hypoparathyroidism due to damage to the parathyroid gland, which increases muscle excitability, causing spasms of the laryngeal muscles. Right. Then how do you manage recurrent laryngeal nerve palsy? How do you manage? If somebody has bilateral recurrent laryngeal nerve palsy, stridor, what is the management?
Permanent tracheostomy tube insertion, sir?
It depends. Now, not essential. It depends on the severity of the stridor. If there is no complete upper airway obstruction, we can initially observe them. Some of them just have a neuropraxia, so they tend to improve within a few days. So we can avoid a tracheostomy. But if the patient doesn't improve in a few days, or if there's significant tracheal upper airway obstruction, then in that case we have to go for tracheostomy. Then hematoma. What is the management of hematoma?
So ideally, after resuscitating patient, we have to rush the patient to the theater because he should be managed best at the theater. And the management includes to remove the sutures of all three planes and decompress the areas.
Okay, so management of a hematoma is removal of the hematoma, which will relieve the pressure, so the edema will be resolved. But where and when you should do is the question. So if the patient is, what we say is, the patient is stable, for example, normal saturation, not immediately life-threatening, we take the patient to the theater under general anesthesia, we do the surgery, evacuate the hematoma, achieve hemostasis and close. But if the patient, if you feel there is no time to do that, if the patient has a you feel the patient is going to die soon of upper airway obstruction, then no place to there's no time for you to take the patient to the theater. In the ward, then and there you remove everything, all the sutures, and let the hematoma come out, which is not very desirable, but that may be the only thing that would save the life of this patient. Okay, then tracheomalacia, what is the management? Sorry, hypocalcemia. What do we do if somebody develops hypocalcemic spasms?
So we have to give 10 milliliters of 10% calcium gluconate over 10 minutes.
Yeah, then?
And then maintenance therapy with calcium carbonate and 1-alpha calci.
Yeah, so immediate management would be calcium gluconate intravenous. That will give you some time, but it's a short-acting treatment, so it will not be like permanent. So for a longer-term treatment, you have to go for calcium carbonate supplemented with 1-alpha cholecalciferol. Tracheomalacia? Okay, you might not know the management. Tracheomalacia, when the trachea collapses, we have to intubate the patient immediately again. Otherwise, the patient cannot maintain the airway. So what we do is we intubate and ventilate the patient for a few days. In most situations, after a few days, the trachea gets its strength back and patient can maintain the patency of the trachea. But if the patient can't, the patient will have to go for a permanent tracheostomy. So those are the methods of managing. So recurrent laryngeal palsy management is once the patient develops it, we have to give airway support with oxygen. Then we might have to intubate the patient then and there in the theater again if the patient has significant stridor. If not, we can manage in the ward. If not, we have to do a tracheostomy. So hematoma, evacuation of the hematoma is treatment, where we do and when we do, how we do it, we have already discussed. Then hypocalcemia, we are correct immediately with IV calcium gluconate, and then supplement with calcium carbonate and 1-alpha calciferol. Another thing is now we never know that the patient has developed hypocalcemic spasms. So we have to look for peripheral features if you're suspecting laryngeal spasms due to hypocalcemia to confirm, because there is no time for you to send the serum calcium and wait for 24 hours to get the report. And tracheomalacia management is immediate reintubation, and if the patient is not settling after a few days, tracheostomy. Right. Next question. Discuss the differences in pathophysiology of hyperthyroidism, Graves' disease, and toxic multinodular goiter. So this should be very, very easy now. We have discussed already. Can somebody answer that?
In Graves' disease, there is production of anti-TSH antibodies, which stimulates the TSH receptors and increase in production of thyroxine hormone. Mm-hmm. In toxic multinodular goiter, there is repeated proliferation of follicular cells and involution, which result in autonomous nodules and increased secretion of thyroxine hormone.
Okay, so in Graves' disease, there are these TRAB antibodies. Sajid mentioned that they go and act on TSH receptors, stimulating the gland. But what makes them hyperthyroid is it is no longer under the control of this negative feedback mechanism. Right? Just because stimulated with the negative feedback can, with reduction in TSH can said patient will not become hyperthyroid. So we need to mention that this overcomes the negative feedback mechanism. They are no longer under the control of the regulation. So that is why they become hyperthyroid. Similarly, in toxic multinodular goiters, this involution, whatever, leads to formation of autonomous cells, which is typically seen in long-standing multinodular goiters. And then these autonomous cells will secrete thyroxine without any TSH stimulation. They are capable of doing that. That is what makes them hyperthyroid. Okay, next one. Discuss the differences in treatment of the two conditions relating to differences in pathophysiology. How do you do that? Can somebody? Yes.
So the Graves' disease is managed medically. usually with anti-thyroid drugs. These anti-thyroid drugs have immunosuppressive action in addition to anti-thyroid effects. So after stopping the treatment after about 1 to 2 years, the patient is likely to recover from Graves' disease. But in toxic multinodal logator, there is no autoimmune reaction. So giving medical after withdrawing the medical treatment, higher thyrotoxicity is likely to recur. So it should be treated surgically to gain control of the hyperthyroidism.
Okay, so Graves' disease is an autoimmune condition. So how do you treat autoimmune conditions? Autoimmune conditions are treated by altering the immunity, either immunosuppression or immunomodulation or whatever. So since Graves' disease is autoimmune, we do that. We control, of course, control is common for both with antithyroid medication, but we know antithyroid medications in addition to that has a immunomodulatory action. You can't call it really immunosuppressive effect. Immunomodulatory action, that is why 40-50% will be cured after 1 to 2 years of treatment. Do we use immunosuppression in the treatment of Graves' disease?
Yes, sir.
When?
In eye disease?
Yes, so you can mention that. Discuss the treatment through two conditions mentioned in 4.1. Graves' disease related to pathophysiology. Pathophysiology, part of it is autoimmunity. So you use immunosuppression to control the disease. So we use methylprednisolone pulses. You may use mycophenolate mofetil, that is MMF. There are so many other drugs that we use. Right? Whereas toxic multinodal goiters, none of those are relevant. It is simply control of autonomous cells with medication followed by definitive treatment, which is surgery or radioactive iodine therapy. Whereas in Graves' disease, those two are those are reserved for patients who do not respond to medical management in general, but there are exceptions. But in general, we try medical management. Only when it fails, we go for surgery or radioactive iodine therapy because of this difference in pathophysiology. So you have to describe that clearly. Okay. So Graves' disease, autoimmune, trap antibodies mimic TSH and stimulate the thyroid, bypass the negative feedback. So uncontrolled excessive thyroxine secretion. Now remember, if you look at this, these are 40-mark questions. So you can't just say one sentence and get away with it. In toxic MNG, we have discussed and what happens. Then treatment, both initial treated with anti-thyroid drugs plus or minus beta blockers. But since Graves is autoimmune, we use these additional treatment modalities. Second line, surgery or radioactive iodine therapy only in selected situations when the primary treatment fails. Then toxic MNG, medications will not cure the patient. Anti-thyroid drugs will only control. So therefore, we have to go for definitive second line treatment, surgery and radioactive iodine therapy. You can discuss the pros and cons if you want. Okay, so the last one is side effects of these treatments. No? What are the side effects of treatments? Okay, so there are a lot of treatments. If you really want, we have discussed anti-thyroid medications. We have discussed the side effects, beta blockers. That's another form of treatment. Surgery, radioactive iodine treatment, and also we have mentioned steroids. So all those are different types of treatments that could be used in patients with Graves' disease and hyperthyroidism. So if you mention all the side effects only, you would get the full marks for these questions. Okay, so these are just the answers, but some other day we can probably discuss how to, I don't know whether I have discussed answering SCQs with your group. Some other day, if you are alone, we can discuss the approach and the planning of an answer to SCQ question and how to do it. Okay, if there are any other questions, are there any other questions? Okay, if there are no more questions, that's the end of the presentation. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.